Assalamu alaikum, everyone. First of all, I would like to welcome to all of you from the platform of Central Manual Therapy. I'm Dr. Dileep Kumar, President CMT. And before we move on to our worthy speaker, and before we start this webinar, just let me know that my voice and my video to all of you guys, so that we should start our webinar. Please put your views in comment box so that we should start our webinar. Is my voice clear to all of you guys? Our worthy speaker is also waiting for the webinar. No doubt she's on time. Yeah. Can you put your views in your comment box? Dr. Nimra, are you there? Okay. Okay. I just need 2 to 3 messages in comment box that my voice is clear to you, all of you. I can hear you and video is clear. Thank you, ma'am. Our the speaker is waiting for us. Kindly from the audience, can you put your, so that we should start our webinar, and our speaker is also waiting for webinar. Yes, Dr. Nimra. Yes, sir. Okay. Thank you, Hafza Noor, for making it comfortable and confirmation. फर्स्ट ऑफ ऑल जैसे कि आपको पता है कि सीएमटी जो हम वेबिनार वीकली वेबिनार्स कराते हैं, इस वीक जो है हमने वेबिनार रखा है डॉक्टर हबीबा थावर के साथ. वी वुड लाइक टू इनवाइट her just before the start of the webinar. I would like to introduce her properly. डॉक्टर हबीबा थावर ये ऐसा कह लें कि जैसे कि पीएचडी हमारी जो फिजिकल थेरेपी फील्ड है, उसमें पीएचडी जो है वो बहुत ही आप कह लें कि गिने चुने हैं. उन शी इज वन ऑफ देम. तो ये एक हमारे लिए, हमारी फील्ड के लिए एक ऑनर की बात है. शी इज पीएचडी इन फिजिकल थेरेपी. एंड डॉक्टर हबीबा थावर जो है वो इंटरनेशनल कंसल्टेंट है एट AKU आगा खान यूनिवर्सिटी एंड AKUH University Hospital. She is BSCPT, MSCPT and PhD in field of physical therapy. She is international volunteer. एंड और उससे भी ज़्यादा बात यह है कि जो इंटरनेशनल पीएचडी होल्डर्स हैं जितने भी पाकिस्तान में, आई डोंट थिंक सो कि बहुत ज़्यादा हैं. शी इज़ वन ऑफ देम एंड वेरी मच टैलेंटेड एंड एक्टिव ऑन सोशल मीडिया as well and in field also. So I would like to thank her first of all that she has permitted me to join us, and I'm very junior in front of her. Just give me a few seconds. It's getting some sort of sorry for the interruption. There is internet issue. I am rejoining. Okay, sorry for the interruption. Well, जो आज का हमारा टॉपिक है वो असेसमेंट एंड मैनेजमेंट ऑफ लो बैक पेन के ऊपर है, और डॉक्टर हबीबा थावर उनके ऊपर जो है वो पहले मैडम से हम सेशन लेंगे. नो डाउट शी इज वेटिंग. तो हम पहले उनको बुला लेते हैं. तो लेट्स वेलकम डॉक्टर हबीबा थावर. फर्स्ट ऑफ ऑल आई वुड लाइक टू आई वुड लाइक बेसिकली मैं उन्हें ही हैंड ओवर करूंगा ये वेबिनार की वो यहाँ से स्टार्टिंग ले, देन वी विल प्रोसीड ऑनवर्ड. So please welcome Dr. Habiba Thawer. Assalamualaikum, ma'am.
Thank you so much. How is everybody? Hello to the audience, to my colleagues. I hope you're having a lovely Sunday. It's a honor and pleasure for me to be here, Dileep. Thank you so much for the invite.
Thank you so much for ma'am joining us, and I will like to excuse just because I was out of Karachi. एंड हमने आपको जो संडे को भी जो है वो डिस्टर्ब किया, तो आपका संडे हमने थोड़ा सा हमने लेना था. तो now just give me 2 minutes that it's now over to you ma'am session, and I would like to join at the end of. I'm hearing all the session. I'm just making myself off the screen. Now it's over to you.
Okay.
Welcome to CMT, ma'am.
I'm going to try to share my screen, so I might need your help, okay? Okay. Let's see if this works. So Dilip, I will need you to provide access to my screen.
Ma'am, this is visible to all the participants. We can see the two views, two windows, one from your side and one from your sharing screen.
Perfect. Perfect. So I have to now see it. Okay. So I'm changing the screen. Can you verify that you see that? Do you see the new slide? It should say the problem.
Yes, ma'am. All we can see the slides that are getting changed.
Okay, fantastic. Okay, so I'm going to begin. So we're talking today about low back pain. And the reason why I chose low back pain is because it's one of the leading causes of poor quality of life in the entire world. And it's associated with significant economic burden. So in Pakistan, for example, if you have a family of four, a mother, a father, two children, and if the sole earner in the family is the father, and his back gets injured and he can't work for 2 weeks, you can imagine the stress that that puts on the family, right? So all around the world, including in Pakistan, low back pain has a tremendous economic burden on people. And I think as physiotherapists, it's important for us to be knowledgeable about how to assess and treat low back pain so that we can help our fellow citizens to get back to work, to feel better, etc. Okay, so that's the reason why I picked this particular topic. Okay, now for us to do a good job with low back pain, I think it's important for us to understand whom it affects, when it affects people. So I'm just going to talk about prevalence a little bit. Who gets affected by low back pain depends on several factors. It depends on gender, whether you're male or female, depends on age. Are you older? Are you younger? Depends on education. Are you well educated or do you have a lower level of education? And of course, your occupation, what you do for a living. Generally, we see more women with low back pain than men. You may have noticed this in your clinical practice that there's just more women with low back pain than men, and this is valid. Secondly, the older we become, the higher the prevalence of low back pain. Logically, this makes sense, right? So the older we are, the more likely we are to suffer from low back pain. And another age-related prevalence factor is that more severe forms of low back pain tend to occur as we get older with age. And lastly, lower educational status is associated with increased prevalence of low back pain. As well, the episodes of the back pain are longer and the outcome is actually worse. That's a really interesting finding, I think. And lastly, the prevalence of low back pain is affected by the type of work we do. For people who do physically active, labor intensive work, the prevalence is much higher than people who do sedentary work. So, somebody who's a bricklayer or somebody who works in construction in Pakistan is more likely to suffer from low back pain than somebody who works in a bank. Okay, so it's important for us to know the factors that put people at increased risk for low back pain. Now, in general, even though low back pain is one of the most common conditions all around the world, and it costs a lot of money, there's a lot of economic burden, it has been treated very poorly. What I mean by that is we are not using the evidence from research that we know. We are not using all the guidelines that we have from experts and from different pain associations. We are not using that body of knowledge to treat low back pain. In 2008, The Lancet, which is a very high quality journal in research, developed a low back pain series working group. And their goal was to provide recommendations on how to stop the mismanagement and mistreatment of low back pain. And they found that in both high and low income settings, meaning in high income countries and middle and low income countries like Pakistan, the same problem was happening with management of low back pain. We were all not doing a good job, okay? We were not following the international guidelines that have been available for many, many years that gives us clear guidance on how orthopedic surgeons, pain specialists, family doctors, and of course, physiotherapists should be treating low back pain. And this group from The Lancet concluded that there were too many complex treatments that were being utilized that were not needed, okay? And that also includes not only from the medical perspective, using complex opioids and pain medications, over testing people with diagnostic procedures, using interventional therapy before using conservative treatment like epidurals and different types of blocks, doing surgery on people when surgery was not indicated, and of course, using physiotherapy techniques for which there's no evidence that they actually work, okay? So The Lancet identified this ongoing issue, and then there were other studies that were done. The care track studies are very important, okay? Because what they found was that in Australia and in the USA, where we like to think that the level of healthcare understanding and implementation is much higher than in lower or middle income countries like Pakistan, even in those countries, they weren't following the clinical guidelines for the care of low back pain. And in 2018, a large meta-analysis was done. For those of you who are not aware, a meta-analysis is when many individual studies are combined to provide a larger set of results, okay? It's a research technique, it's a data analysis technique. So in 2018, a meta-analysis was done, and they indicated that an increasing number of MRIs have been requisitioned over the past 21 years in individuals with low back pain. Now, this is a problem, okay? Because we know that just because somebody has an MRI of the low back doesn't mean it's telling us the whole story, okay? For example, we could take an MRI of my back, for example, and I could be complaining of extreme back pain, okay? So much back pain that I can't do anything at all. 20 out of 10 back pain on the pain level. I'm bedridden. This is what I tell my physiotherapist. But when my physiotherapist looks at my MRI, it's completely clear. There's no degeneration. There's no facet arthropathy. There's no spondylolisthesis or spondyloarthritis. There's nothing. My MRI is completely clear, okay? So just because somebody has extreme low back pain doesn't mean that by doing an MRI, you're actually gonna help identify the cause of that pain. But the opposite is also true. You could have an MRI of an individual who's 35 or 40. They could have extreme degenerative change at multiple levels. They could have degenerative disc disease. They could have a disc bulging where the disc may be pressing on the thecal sac, for example, but they're completely pain-free. If you were to sample 4 or 5 or 6 people out of 10 and take an MRI of their spine, you would likely find some degenerative changes on those MRI images, but these people don't have any back pain. So what I want you to think about is it really valuable to send a patient for an MRI if they have low back pain? Is that really necessary as a first step? It's not. The first step is conservative treatment, and we're going to talk about that a little bit later, okay? What I want you to understand is that the MRI is not the gold standard for low back pain. It's the gold standard for other things, but it's not the gold standard diagnostic for low back pain, okay? And a lot of times, patients, we are adding to their financial burden by asking them to go get an MRI when it won't really tell us much information. Okay, the other problem with the mismanagement of low back pain is that one of the most common surgeries that are done is a discectomy. This is when surgically a disc is removed and 2 spinal vertebral levels are fused. This is called spinal fusion surgery or discectomy. There's actually no evidence, no robust evidence to show that this surgery is of any benefit to patients who compared to non-surgical care for patients with low back pain due to spinal degeneration. Okay. However, in the USA, for example, elective spinal fusion surgery from 2004 to 2015, over 11 years, increased by over 60%. We don't have the numbers from Pakistan, but what I would ask you to do is think about how many patients you've seen in your clinical practice, in your OPDs, who've had surgery, spinal fusion surgery, but who come back to see you because they still have pain, okay? There's no evidence, no robust evidence that this type of surgery actually helps the patient who's got low back pain associated with spinal degeneration compared to conservative or non-surgical care. In other words, compared to physiotherapy, compared to what you and I can do, okay? So we know that we're not doing a good job medically, surgically, and from a therapy perspective, solving low back pain. So the Lancet Working Group made a proposal to the World Health Organization, and they said that we really have to pay more attention to ensuring that patients do not undergo excessive medical solutions. And we need to follow the established guidelines by experts on how to treat low back pain. So what I'm going to do now is I'm actually going to summarize what those guidelines say, focusing on what you and I, as physiotherapists, can do to help our patients. I identified 6 major international clinical guidelines, NICE, APTA, etc. Those are just 2 examples. And every single one of those guidelines that's been published since 2016 prioritizes non-medical approaches for management of patients with low back pain. That means physiotherapy, psychological treatment, and exercise, okay? That puts a large responsibility on you and I as physiotherapists to deal with low back pain. So I'm going to highlight the types of treatments that you and I as physiotherapists can use to help our patients with low back pain. And then I'm going to talk about the treatments that have no evidence to support their use, okay? And you might be a bit surprised. You might be a bit shocked. You might get a bit upset, but that's okay. I want you to start thinking about what treatments to use. I want you to start thinking about using research to guide your clinical practice. Okay? All right. So the first thing we need to do is, obviously we have to provide a diagnosis, correct? Not necessarily. Okay? A patient walks into your clinic or your OPD and they tell you that they've had low back pain for 2 years. Okay? You can provide a diagnosis of mechanical low back pain, lumbar strain, lumbar sprain, whatever you want. It really doesn't matter, okay? Because you're not going to treat the diagnosis, okay? You should not treat the diagnosis. What you should treat are the impairments, okay? It's also not important, based on the clinical guidelines from the experts, to try to identify the structure or actual anatomical structures that are causing the pain. It doesn't matter. It's irrelevant. We don't have the clinical skills, the clinical technology to identify whether pain is coming from a specific vertebral level, a specific facet joint, a specific disc level, or even a series of nerve roots. We may think we do, but it's actually extremely challenging to pinpoint the anatomical structure that is responsible for somebody's low back pain because of the complexity of the anatomy. Not only because of the complexity of the anatomy, but we all know that anatomy varies from one person to another person. There may be anomalies, okay? So it's not important to focus on trying to identify which specific anatomical structure is responsible for the pain. Rather, what I would recommend is you do your clinical exam and identify impairments that are limited because of your patient's low back pain. So for example, is range of motion limited? Is there adverse neural tension when you do the straight leg raise? Is there a decreased internal rotation of the hip? We know that decreased internal rotation of the hip is associated with low back pain, right? So you want to look for impairments, okay? Because if we treat and address those impairments, then we're going to make an impact on that patient's disability, and in turn, on that patient's functioning, and in turn, we're going to improve that patient's quality of life, okay? So from this slide, what I want you to take away is don't treat the diagnosis. Treat the impairments that you as a physiotherapist identify during your assessment. Okay, now, if somebody walks in with non-specific low back pain, so for example, a 45-year-old male or female, 45-year-old female walks into your OPD or clinical practice and says, I've kind of got low back pain around my low back. There's no pain in my leg. I don't have any sensory changes. There's no tingling or numbness. There's no referred pain. You know, if I sit for too long, it kind of bothers me. I feel a dull ache. When I stand and walk around a little bit, it feels better. Sometimes when I bend, it hurts, but sometimes it feels better. So I don't know what's going on. Can you help me? First thing you need to do is take a history, a thorough history. Then you want to examine the patient. Even though there are no neurological changes reported, there are no radicular symptoms reported, you want to rule out all red flags. And I'll provide a slide indicating what red flags are for low back pain just a little bit later. You also want to do a thorough neurological examination. That means dermatomes, myotomes, and reflexes, okay? Because even though the patient is not reporting radicular symptoms, you want to make sure that there aren't any. You want to exclude radicular symptoms to the best of your ability by using dermatomes, myotomes, and reflexes, and special tests such as a straight leg raise in sitting and in supine. You also want to look at psychosocial factors, because we know that psychosocial factors play a big role in perpetuation of pain, particularly in chronic pain, okay? Only if you find red flags would you want to recommend imaging. Otherwise, imaging is not recommended. Only if you identify true red flags, which indicate serious pathology, only in that scenario should you recommend the patient get imaging, okay? Now, what if you get a patient who's a bit more complicated, low back pain, but with sciatica, clear referred pain? Again, you must take a thorough history and you must do a physical examination to identify or rule out red flags. We'll review those in a moment. Again, you must do a neurological examination, dermatomes, myotomes, reflexes, SLR, and any other special tests that you prefer to verify the patient's symptoms of sciatica, okay? Because oftentimes the patient will confuse sciatica with hamstring tightness. The patient will confuse sciatica with adverse neural or dural tension in the nerves along the posterior aspect of the legs or the posterolateral aspect of the legs. So you have to verify true radicular pattern, okay? Again, if you have positive red flags, then and only then should you recommend imaging. Otherwise, please discourage routine use of imaging with your low back pain patients. Again, you must look at psychosocial factors. Is there a history of depression? Is there a history of other chronic diseases? And then lastly, because we've got sciatica involved here, you want to ensure that you do a differential diagnosis. You want to rule out things such as metastatic spinal cord compression, spinal injury, perhaps a compression fracture, spondyloarthritis, etc. Okay? Here are the red flags of low back pain. So from a history perspective, you want to ask your patient if they have active malignancy or a history of malignancy, because we can get reoccurrence, okay? You want to ask your patient if they've experienced unexplained weight loss or unexplained loss of appetite, because those two reports can indicate serious underlying pathology. Ask your patient if they've experienced a recent fever or chills or infection, if they are immunosuppressed, okay, so if they have had a recent transplant or a history of transplantation, if they experience pain at night or pain at rest, this is a red flag, a serious red flag. Something serious in the body is going on if they're experiencing pain at rest or pain during the night. Usually back pain occurs with movement or with activity, right? It doesn't just happen at rest. Usually it's not constant, it's intermittent. If you do a thorough history, you will find that it's typically intermittent and occurs with activity and rarely occurs at rest or during the night. Trauma, have they had a fall? Have they been hit by a cricket ball against their spine? Have they been in a motorcycle or car accident? And of course, recent onset of bowel and bladder dysfunction. Bowel dysfunction means they lose their bowels. Bladder dysfunction means they're unable to empty their bladder. Okay, those are red flags. From a physical examination perspective, the red flags that you want to look for are fever, anal sphincter weakness. Okay, again, they are unable to hold their bowels. They empty their bowels. They have an accident in their trousers. Okay, anal sphincter weakness, saddle anesthesia. All right, they are unable to feel around the groin area, around the reproductive organs, the vaginal opening, the anal opening around the penis and testicles. So you have to ask specifically, and you may have to test that with their consent. And lastly, progressive neurological deficit in the lower extremities. This is a red flag, okay? If you have patients with red flags, you need to ensure that they remain calm, but these individuals are essentially a medical emergency, okay? We're looking for cauda equina type symptoms, right? Those are red flags. If you find cauda equina symptoms on your history and on your physical exam, this patient is a medical emergency. They should be sent to the emergency room. with clear instructions on what your findings are. All right. So it's really important to always, always, always do a thorough history, a thorough physical exam to at least rule out your red flags. Okay. I'm going to focus now on the types of treatments that the research to date and the clinical guidelines from 2016 to 2020 have indicated physiotherapists should be using with their patients with low back pain. Okay? The three main things are self-management. It is our ethical obligation to provide our patients with education and counseling to make them as independent as possible in managing their various conditions, including low back pain. Okay? And generally, the education we must provide on the nature of the condition, the nature of the low back pain, and we should encourage them to continue with their normal activities as much as possible because we don't want deconditioning to set in. The second intervention that is indicated for physiotherapists to use from research is exercise. And there's a lot of variation in the type of exercise. It can be biomechanical, it can be aerobic, it could be mind-body, like yoga, or a combination of approaches, including aquatherapy, core stability, a walking program, a general body strengthening program. There's a lot of options. And lastly, manual therapy, but very specific manual therapy, spinal manipulation or mobilization in combination with soft tissue techniques, but only, these techniques are only effective if they are combined with exercise, with or without cognitive behavioral therapy. And I will talk a bit about cognitive behavioral therapy a little bit later, okay? So if you're gonna use manual therapy, you need to know what kind of manual therapy to use. You need to know which patients to use it on, who will respond most favorably to it, and I will give you that information. And thirdly, you have to use the manual therapy with exercise. Otherwise, there'll be no long-term benefit to your patients. Okay, these are the interventions that we all use. I see these being used every day in different clinics, in different OPDs, on YouTube, on Twitter, on Facebook, but there's absolutely no evidence to support any of these as being effective treatment modalities in low back pain. This may come as a bit of a shock to many of you. It may be disappointing because many physiotherapists all around the world, including in Pakistan, spend lots of money learning about acupuncture, doing courses on acupuncture, doing courses on different types of manual therapy, doing courses on instrument-assisted soft tissue mobilization, doing courses on other types of taping techniques, but there's no evidence to support the majority of these adjunctive therapies, okay? If you have to use a machine to make your patient feel better, then you're not really following evidence-based practice, okay? That's my advice. It's up to you if you decide to practice in that manner, but I really recommend that you review recent literature and you look at the clinical guidelines that have been published by the APTA, by the Physiotherapy Association in Canada, in Australia, in the United Kingdom, because they've coalesced all of the research to allow us to practice very effectively to help our patients. And these techniques that I've listed here on my slide are not very useful. So I encourage you to shift to using this combination of techniques as opposed to this combination of techniques. Okay. All right. Now, as a quick review, if somebody comes in with acute low back pain, you always want to reassure them on a favorable prognosis. Okay. There's clear evidence in the literature that low back pain is a self-limiting condition. What that means is how a patient responds to low back pain, i.e., whether they get better stay the same or get worse depends on the patient and their outlook about the condition. Okay, that's what self-limiting means. So you want to, from day one, reassure the patient that, you know what, it's not serious. I've examined you. I didn't find anything serious. Please don't worry. Do activity, remain active. Your prognosis is favorable. You don't need any fancy medication. You don't need any fancy diagnostic testing. If you follow my evidence-based advice, you will get better. Encourage them to return to their normal activities. If they like to run, tell them, go start walking, and then gradually jog, and then start running. Okay? They should be avoiding bed rest. Bed rest is the worst thing that anybody can recommend for low back pain. Okay? It's okay for them to use NSAIDs or non-steroidal anti-inflammatories and weak opioids under medical direction for short periods of time. And if you find that you've been practicing using evidence-based methodology and they're not significantly better in 4 weeks, then you should refer them to a specialist for further investigation. The specialist could be an orthopedic surgeon, could be a neurologist, could be a pain specialist, okay? For somebody with chronic low back pain, the treatment is very similar, but there are 2 differences. The first is a greater focus on exercise therapy. Why? This is because these patients will likely be significantly deconditioned. Chronic means that they've had this low back pain for more than 3 months, which means likely years, right? I get low back pain patients who've had the pain for 2, 3, 10, 20 years, okay? So they're chronically deconditioned. They have significant muscle atrophy. They have no idea how to activate their core stabilizers. No idea. So exercise therapy in chronic low back pain is very important, and psychosocial interventions because we know that chronic pain and what a person's mindset is, their psychological philosophy, those 2 things are linked very closely together, okay, and can affect each other. But again, if you use an evidence-based approach to treat these patients with chronic low back pain, but after 4 weeks you don't see a significant improvement, you should redirect their care to a specialist, all right, for further investigation and assessment. Okay, so now I'm going to share with you some what I call clinical pearls. These are techniques that you and I as a physiotherapist can use to help our patients with low back pain. These techniques have been shown to be effective in certain scenarios. I'm going to share those scenarios with you, okay? The first is thrust and non-thrust mobilization and manipulation. Remember, you have to use this in combination with exercise and or psychological counseling, okay? But not every single patient will benefit from thrust and non-thrust mobilization and manipulation, okay? It's important for you to understand that. Not every single patient will benefit from it. So we need to know which patients to use thrust and non-thrust mobilization and manipulation on. Acha. So I'm going to share that with you right now. Typically, you want to use this on a patient who's had symptoms for less than 2 weeks, less than 16 days. They should not have any symptoms below the knees. So there should be no referred pain below the knees. There may be lumbar stiffness or hypomobility that you may have assessed by doing your assessment. And you need to have at least one hip that has greater than 35 degrees of internal rotation, which also means that you're going to have some hip hypomobility. And on a questionnaire called the Fear Avoidance Beliefs Questionnaire, they will have a score of less than 19, which means that they are using fear avoidance behavior. They are avoiding activity, movement, exercise, work, etc., because they are fearful of experiencing more pain from their low back, okay? If you have a patient that fulfills those criteria, then you want to be able to use thrust and non-thrust mobilization or manipulation with those patients, because the success rate that the manual therapy will be of benefit to them improves from 45% to 95%. It doubles, okay? So picking and choosing who to use manual therapy on is very important in combination with exercise and or CBT. What about trunk coordination, PNF pattern type movements, strengthening, abdominal strengthening, endurance exercises such as low weight, multiple rep exercises in rotational patterns. So again, some patients will benefit more from stabilization type exercises than others. Typically younger patients, patients who are under the age of 40, patients that have a prone instability test that's positive. A prone instability test is, in case you don't know, the patient lays on the table in prone, but their legs are off the table on the ground. The therapist applies a posterior to anterior pressure on the spinous process segmentally, okay? The patient's back must be completely relaxed. If there's pain with the posterior to anterior pressures, and that pain is eliminated when the patient's legs are raised because they're stabilizing their spine and the musculature around the spine, then that's a positive prone instability test. So if the patient's age is less than 40, if the prone instability test is positive, if there are aberrant movements with motion testing, okay? So movement patterns are off when you're doing motion testing. And if the straight leg raise is greater than 91 degrees, so you've got hypermobility basically, then this type of patient with low back pain would respond very well to stabilization type exercises, to a core stability program where you do bridging exercises, transverse abdominis activation exercises, forward planks, side planks, etc. Okay? What about centralization and directional preference exercises and procedures? So here I'm making reference to the McKenzie methodology of centralization versus peripheralization and preferential directional treatments of exercises. These can be utilized if you can identify in your assessment a clear pattern of centralization with repeated movements. What this means is, for example, you'll have a patient who comes to you and they say, Dr. Saiba, I have low back pain, and the pain goes into my right buttock, down the side of my right thigh, and into the back of my right calf, okay? And you do your assessment, there's no red flags, and you do a McKenzie assessment where you ask the patient to do repeated flexion and standing, okay? That may make the symptoms worse, okay? It does not centralize the symptoms, which means it does not eliminate the symptoms from the calf or the thigh to focus just on the back. But then you might do repeated extension in prone lying or repeated extension in sitting, and that actually results in centralization. What that means is that there's elimination of pain from the calf, the thigh, and the buttock, and the patient only feels the pain in the low back, even if the intensity of that pain is greater in the low back. It's okay. That's centralization. So if you can find a clear pattern of centralization or directional preference of movement with exercise, then you can utilize repeated movement as a type of treatment in patients with acute low back pain, with or without referred pain, and in patients with acute, subacute, and chronic low back pain without referred leg pain, but with mobility deficits, okay? Now, you might wonder why. I have my own theory as to why that might work, and we can discuss that during the Q&A session. I'm almost done here. Oops, missed a slide. Okay, what about flexion exercises? You know, many times we're taught in school flexion is bad for the spine. Bending is bad for the spine. That's actually not true, okay? Flexion is only bad for the spine if you can prove that it causes peripheralization of symptoms. Otherwise, flexion is perfectly acceptable for individuals with low back pain. Only using the McKenzie methodology, if you can prove that repeated flexion causes peripheralization of symptoms, then and only then you would temporarily avoid flexion. Otherwise, it's perfectly okay to use flexion exercises with your patients in combination with manual therapy in the right demographic of patient, along with strengthening exercises, nerve mobilization procedures, progressive walking. And ideally, this group of interventions is best in older patients with chronic low back pain, with referred pain, okay? Why do you think flexion exercises would work best in the elderly population? Think about what type of processes occur in the spine as we age. Our spine degenerates. The joint spaces begin to collapse. So by doing flexion, we're actually gapping, we're creating space in the spine. So if you think about what the clinical recommendations are, logically, if you have a good understanding of your anatomy, they make sense, okay? As a physiotherapist, this is how you want to think. When a research paper tells you this works, you want to think, okay, anatomically, does that make sense? Does it make sense that this particular technique works? You want to be critical of everything you read, okay? Now, what about lower quarter nerve mobilization procedures? Basically, that's a fancy way of saying neuromobilization techniques for the lower extremities, all right? So we know that with an acute case of low back pain, you're going to get inflammation, you're going to get adhesions, scar tissue forming. We want to make sure that nerve roots and nerves are moving nicely within their sheaths, that they're not getting tethered or stuck. And there's some evidence that by doing neuromobilization movements and procedures, we can positively affect pain and disability in patients with subacute and chronic low back pain and radiating pain, okay? So there's different ways to do these procedures. And again, we can review that during the Q&A. All right, now I think this is probably one of the most important slides. Patient education and counseling. As a physiotherapist, you know, I've seen some physiotherapists do excellent patient education and counseling. They spend quality time with their patient. They reassure them. They minimize the fear factor of the pain and the condition. But we also have to add a different component of education when we work with patients with particularly chronic low back pain. We have to add what we call behavioral education, or CBT, cognitive behavioral therapy. I know that in Pakistan, there are a few of you who have done this course, so you can be mentors for your colleagues, okay? What is CBT? I'm gonna give you some concrete examples. CBT is when you talk to your patient about remaining active despite their low back pain using pacing strategies. So for example, instead of cooking for 3 hours straight, you tell your female patient to cook for a half hour and then to take a break. Go do something else. Then come back an hour later and do another maybe half an hour to 45 minutes of cooking. So break up a 2 or 3 hour task into smaller pieces. The advantage is the patient is able to continue to be active. It builds up their self-confidence, and it shows them what they are able to do versus what they are not able to do. We want to focus the patient's attention on what their abilities are, not what their inabilities are. Okay? Now, I've listed other examples here. Goal setting is one of my favorites. When I have a patient with low back pain come to me, one of the first things I ask them is, tell me 5 things that you can't do now that you want to be able to do in 6 weeks. It could be something as simple as making my cup of chai myself, being able to make a cup of tea for myself, or being able to go to the bathroom without anybody helping me. If you identify what the patient wants to do, then you can simulate your exercises and your therapy towards those goals. Okay? So behavioral education is very important. I encourage my physiotherapy colleagues to pursue postgraduate training and education in this, particularly if you are working with many patients with low back pain. This will really enhance your practice and the effectiveness of your treatments. We're almost done. Now, we also want to educate the patient from a physiotherapy perspective, but we want to be very careful about what we tell our patient, okay? We don't want to scare them. We don't want to tell them, your back is in really bad shape. Don't do this, don't do that, because that's actually going to make the situation worse for the patient. We want to be very positive, very reassuring. Many OPDs and clinics have anatomical models. Bring the anatomical model. Show the patient, this is your spine, this is your disc, these are the nerve roots, these are the vertebral bodies, these are the muscles. We're going to try to work on stabilizing this whole area by strengthening your muscles. It's important for them to be able to visualize the anatomy that they're trying to activate during physio, okay? Explain to them how pain works, because they need to know how their body perceives pain. Because if they know how pain works, then they will appreciate attention diversion strategies, okay? They should also understand that the overall prognosis for their back pain is very good, okay? There's clear research that if you and I get back pain and we don't get any treatment, 0 treatment within 2 years or less, we'll be completely pain-free. Very rare is it that back pain is pathological, okay? Most chronic low back pain is not pathological. There's nothing serious going. It's a combination of psychological factors, deconditioning, and a heightened pain threshold. All right? So it's important to convince the patient that the overall recovery chance for them is very good. Encourage them to remain active. Encourage them to keep doing their normal activities, to return to work as much as possible, and reassure them that if they experience a little bit of pain with those activities, it's okay. That's not going to cause any damage. That's normal, okay? And instead of focusing on how much pain is improving, try to focus on other things. Try to focus on how their activity levels is improving. So instead of asking them, is your pain better when they come to see you? Ask them, have you noticed that can you walk further? Can you stand longer? Can you now cook for 45 minutes before taking a break? Focus on functional activity improvement versus pain improvement. Because the reality is, in a chronic pain patient, it's very rare to completely eliminate their pain. It's very rare to make them completely pain-free. Don't put that expectation into your patient's mind, because then you will definitely not succeed. Focus on their functional improvement, not necessarily an improvement in their pain. The reality is the majority of these patients will experience some pain improvement, but they're going to have pain for the rest of their lives. They have to learn how to live with the pain. So focusing on what they're able to do is very important. Okay. Now, what about more aggressive exercise, more aggressive fitness activities? So for individuals who have chronic, long-standing low back pain without any other pain anywhere else, all they have is low back pain, no other pain anywhere else, you can actually use moderate to high intensity exercise and they will get better. Okay? Their functional abilities will improve, their activity tolerance will improve. For individuals with chronic low back pain plus generalized pain, so for example, they have low back pain, but they also have shoulder pain, they have bilateral foot pain, they have mid back pain, they have neck pain, they have headaches, they might have hip pain. It's kind of non-specific, generalized pain. We have to be a bit more cautious with them. So you want to start with low intensity endurance exercise, and you want to increase that very, very gradually. Okay. Okay. Now, one thing that I found in Pakistan is most physiotherapists use some sort of tool to measure improvement. Usually it's the numerical pain rating scale, where they ask a patient 0 to 10, how bad is your pain? And hopefully from the initial assessment to the 4th or 5th session, the patient's pain will have improved from a 9 out of 10 to a 2 out of 10. But that's not enough, right? Because especially with chronic low back pain, we want to focus away from pain and onto function. So what I'm encouraging you to do, if you don't already, I think some of you use these questionnaires, but for those of you who don't, I'd like you to consider using them. There's some examples here. These questionnaires look at day-to-day activity and how, as you treat the patient, their day-to-day activity tolerance improves. I'm going to show you the Roland Morris Disability Questionnaire. It's basically 20 questions, 20 statements, and if the patient's back pain at the present time, when they are doing the questionnaire, is affecting their ability to do one of these tasks, then they check it off. The higher the score, the worse. The lower the score, the better. So you want the patient to go from a score of 14 after 6 sessions to a score of 4 or 6. That means that your treatment is working, and most importantly, that they're noticing an improvement in their functional activities and hence in their quality of life. Okay, so for example, I get dressed more slowly than usual because of my back pain. I avoid heavy jobs around the house because of my back pain. Because of my back pain, I am more irritable and bad-tempered with people. Because of my back pain, I go upstairs more slowly than usual. Okay? So we want to see them improve. So they'll be checking off fewer boxes if your treatment is working. Okay, I think that's all I have. So I'm going to eliminate my screen sharing. Let's see if I can figure out how to do that. Stop screen. All right, fantastic. Where is my colleague?
Thank you so much, ma'am.
Hi, welcome back.
Thank you so much, ma'am, for such a wonderful and informative webinar. One thing I wanted to add that usually all my webinars that I collaboratively work with different speakers, I need to say that please put your evidence whatever we speak. But this is my first webinar along with you that I couldn't say my participant that this is all about the evidence supporting, because you have mentioned it is very well. There are few points that you just verbally what we can say presented in front of the audience, but I have some strong evidence suggesting and supporting your points. Actually, I did some certification in spinal therapy from Lahore. The few points that you verbally suggested, but they are supporting. I would like to share with them. One point that you added, that the psychological factors and the demographic are what we can say disability factors that are contributing in case of the low back. There is a study, Foster Pain in 2010. I will provide them to all the participants. Individual, the psychological factors, they account at most 2.5% of the low back pain. The disability and the demographic factor, they account for 50% of the low back pain. This is a study from the Foster and in 2010. After that, the one strong point that is suggesting your another point is the that we usually do. You shared a case of discectomy. I would like to share one case of few patients that I was treating in Karachi. They did discectomy. Maybe the patient and the doctors would be. I appreciate that they would be seeing this webinar or not. Acha, make sure my voice is clear. Kaina Tazim is saying that my voice is not clear.
Yeah, there's a little bit of interference. Do you have a phone? Do you have a mobile phone next to you? If you have a mobile phone, just deactivate it. Sometimes it interferes. I just want to say hello to everybody. I'm so happy that you're able to join us. Please, if you have questions, type in the comment box, and we'll do our best to answer them. Okay?
Is my voice to you now?
It's a bit better, but there's like a buzzing sound. I don't know where it's coming from.
Yeah, sir. Ma'am, actually, I'll better.
That's much better.
Okay. Thank you, ma'am. Another point that I was going to discuss with you, that I have seen many patients in my clinical practice. I wouldn't take the name of the orthopedic practicing in Karachi. Basically, the patient was complaining basically from just low back pain, and he came to you that the bending is mostly causing the pain, while all the other movements, they were pain free. After few weeks, he suggested that the personal orthopedic has recommended him for the surgery, not go for the physiotherapy. So he basically texted me that I am going for the surgery and all. What would you suggest me, doctor? I said, you can go. He is your basically family, or what we can say, you trust him better than, so you can go. He went for the discectomy, and after 6 weeks exactly, he texted me that, sir, I have a same pain. I have a same pen. I'm literally speaking. I have a same pen that I was. So what should I do? I said that you can go to a better physiotherapist for assessment, and let's see then what happens. He again contacted to the same orthopedic, and he said that you can go another discectomy. So I don't know. He went another side. Within.
You remember the slide I showed you? There's no evidence that spinal fusion or dissection helps low back pain. If your patients, educate them, encourage them to pursue physiotherapy as their occupation. Don't let them go for surgery. They will not get better. They won't get better. They're going to spend 40,000, 50,000 rupees, and they will not get better.
So this point was also suggesting, and finally, the muscle changes. There's a systemic review study in 2013 by Wong. The muscle changes are consequences of LBP, not a cause. Most of the in Asia and in Pakistan, the physiotherapists often say that due to the muscle spasm, you have a low back pain. That's very often what we can say the correct statement. But the muscle changes, the consequences, not the cause. So muscle imbalance.
Yeah, what happens is you get low back pain. Your patient gets low back pain. They get scared. They don't move. They stop all their activity. They stop their housework. They stop working. They stop walking. They stop going to the gym. They stop doing everything. Then what happens? Then the body begins to break down. Your muscles begin to break down. Right? So
there's another point that I wanted to add, that that you said that we shouldn't, what we can say, use some statement to the patient not to give a positive negative fear. Like most of the statement that we use, your back wears out you as get older, you don't have to bend, your back is weak. Like these are the terminology put basically a negative impact on the patient that you. And lastly, the point that the radiological are not suggestive of that, that was strongly, we can say there is a systemic review over it, that if we do MRI of the 6 asymptomatic patient, then there would be evidence of the disc bulge. Like if I don't have a back pain, I am asymptomatic, but if I do a back my back, I would have a disc bulge or maybe a disc protrusion. So this is what
I have no back pain, zero, but I've got 2 bulging discs in my back. I have no back pain. So don't rely on MRI. When a patient comes to you and there's an MRI diagnosis, it doesn't mean anything. Do your own clinical exam. Trust your clinical exam. Okay, that's more important than the MRI.
Okay, and lastly, I would like to say that in Asia, or we can say in Pakistan, the main barrier that I feel myself, I'm not a much experienced like you, ma'am. I just have a 3 to 4 years of clinical experience. I am 2017 graduate. Then I did my post graduation from Lahore in 19. Well, I don't have a many years, several years, like 10 to 20 plus years of clinical experience like you. But one thing I have noticed that there is a barrier of assessment that we don't rely over it, that happen physios don't do. Just like if you are putting a hand over your shoulder, then you have a frozen shoulder, it is diagnosed from the door of the clinic that you enter. If you come with a hand on your back, then you have a disc herniation or a disc slip that you enter at the OPD. So these are the some misconceptions that I often say to my participant, and you have cleared it very well.
Yeah, I want to reiterate. I want to make 2 points. Okay. In Pakistan, and I don't want to offend anybody. It's just an observation. Okay. In Pakistan, seniority is based on how many years you've been a therapist. People think that. Sorry, it's my phone. Give me 1 second. Hang on.
Okay, ma'am. Okay. All the participants are requested to kindly put your feedback in the comment box and like the video, and also put your feedback regarding the session, regarding the speaker, Dr. Habiba Thawer, on our CMT FB page, and keep continuing to ask the question. We will answer it right after, within the few minutes at the end of this session. So please put your feedback in comment box, and you can ask directly in question in the comment box. So we will try to answer you as soon. And secondly, all the presentation and the evidences that we were talking about, I will provide you all the data that we are going that we are talking about. All the
Dileep, I will send you all my references. Don't worry. Okay, you will get them all. Just give me a couple days. I'll send you all my references. Our colleagues can access them online on PubMed or through Twitter. Okay. Okay. So I want to say 2 things. How good a therapist is not dictated completely by how long they've been a therapist for. Okay? You can take one therapist who's been a physio for 10 years and another one who's been a physio for 5 years, and the one who's been a physio for 5 years might be better. Why? Because they read research. They keep up to date with research trends. So in Pakistan, we have to change our mindset a little bit. You know, it's very important for every single one of us, including me and you, everyone, to read research and to share ideas about how to treat patients. Okay? The second point, I can't remember what it was, I forgot. It's okay though.
Okay. Last points I wanted to add, that there are some I will provide all the presentation and references that we were talking about. Some students basically have privately texted me. I will provide them. There are some facts regarding the low back pain, and ma'am has cleared all the concept, but there are some few points that I wanted to add that are very common, that you don't have to worry about it. Number 1 point is back pain is common. Why you worry about your back pain more rather than your shoulder pain and neck pain. The pain is pain, then we need to get treated, so let it be some light. Second point, scan means radiographs for the back pain, they are rarely needed. As the ma'am already have discussed, there is no such evidence supporting. Oftenly we have a back pain, the physios and orthopedic refer for the x-ray or MRI. Don't put further pressure financially. Everyone is not supporting, or we don't know about their classes basically they belong. So let's elaborate this more. Number third point, the back is not that vulnerable to damage. Why you are worrying about your back, that it is very easy common point that is going to be damaged. Like if I put a 5 kg weight and I will damage my back. This is not as easy, as weak as you are thinking about, that if I am putting any. And the last thing that ma'am said, that if you don't let them, don't limit the movements, don't limit their movement. Like bending is causing me pain, I should take a bed rest of the several months, then I go in a severe spasm, and you are basically worsening your pain, you are not treating it. Number
Exactly.
4 point, the back is designed for the bending and lifting. I am providing you evidence. Most of the physios and most of the doctors, what they do, if you have a back pain, please don't bend your back or don't lift the weight. Why? I can provide you the evidence that the back is basically designed for the lifting and bending. So please, you can make it, you can limitize for a few days, for a few we can say weeks, but don't make. Number 5, you can have a back pain without the back damage, already discussed several times. You can have a asymptomatic, you can have a symptomatic pain, but you can't diagnose it because of several assessment. Number 6, don't take back pain lying down and don't rush it for the surgery. What I can say, this can be a controversial.
Dileep, I really like that. Controversy is good. We need to shake it up a little bit. We need to prove that physiotherapists can make a huge difference in managing back pain. I love that.
One thing I won't say controversial, but just I am saying that what the evidence says. So I'm just talking about this so that the others, they are watching and who think that this is a controversial session or not. So I would like to say that I can provide you the evidence what they are saying. Number 7 point, exercise is good for the back pain, but people are often afraid. So don't afraid them furthermore. Let's encourage them to do the exercise. That's a very good. Like the medication have a temporary effect, but if you get a pain relief with the help of exercise and physiotherapy or yoga basically, so you are doing a very fantastic job. After that, number 8, strong medication, they don't have a strong benefits for back pain. I can provide you the evidence. Like the antibiotics, that's our first that the physician or what they refer basically. Don't go for the medication, they have a side effects. Go for a physical therapy or the yoga or other. Number 9, second last point is that buyer भी एक study है मैम, the back pain can get better. Of course you can treat your back, but be confident that you are what you are doing. Most often people say that I have done a physiotherapy of a 5 weeks a session and I am not getting better. If I take a single pill painkiller and I get better. So please put your remarks regarding that the exercise is more better. It will increase the what we can say the strength, but the medication have side effects on your all the system like the GIT and all. Well, these were all the simple points with a strong evidence that I just put forward. While the remaining webinar is almost clear, I don't think so. There is an query. If any participant has query regarding this, ma'am is here. You can ask directly in the comment box. And secondly, put your feedbacks. And if there is no question, then we will get the words of guest from the from our respected speaker, and we will wind up this.
I remembered what I'd forgotten. How we talk to our patients is very important. You said that there are certain phrases we use. Your back is fragile. Don't do this, don't do that. We can't use that wording anymore. We have to do the opposite. Your back is strong. Your body is strong. Your body will bounce back. Your body knows how to recover. Don't baby your body. Be aggressive. Do activity. You know, when I get back pain patients, the first day, they're on a treadmill. No modalities. No modalities. Okay? They get exercise, balance exercise, core stability exercise, and treadmill. And they all get better. They don't get IFC, they don't get heat, they don't get acupuncture, they don't get soft tissue assisted instrument massage, nothing. I don't use machines. It's all education, counseling, CPT, treadmill, balance, and strengthening. A lot of education, a lot of talking. Try it, it works. It works really, really well.
Ma'am, I would have a small disagreement with this point. Like I'm also an acupuncturist and I'm also a manual therapist as well. I have some certification in these courses.
Yes.
Different manual therapy approaches that you said, you can use different manual therapy approaches with the conservative or traditional method that we are doing in Pakistan and Asia. But there are some approaches, like Mulligan says, that if you are not getting better with my manual therapy approach, you can go another treatment with my technique. Okay, but most of the other approaches, like the CREX is there, orthopedic medicine CREX is there. Sure. He says if you use any technique with my approach, you will not get a better results. So if you want to use my technique or if you want to apply my techniques, then go purely with it. Secondly, I come to the acupuncture point and the needling. If in Asia, or what we can say in Pakistan, if these techniques, they are the satisfactory to the patients only, we have to also satisfy the patients. So if the patients they have an instant relief, basically.
Yeah, if as long as we understand that there's no evidence for majority of these modalities for significant long-term benefit. But I understand that sometimes the patient demands acupuncture or muscle stim. It's up to you. Okay? I say no. No, I'm not gonna do that. If you value my judgment, if you value my education, if you value my expertise, you will listen to me, Mr. Patient. Either they do or they don't, right? So it's up to you. I also am acupuncture certified, but I don't use it for low back pain because there's no evidence. I use it for other things, but not for low back pain. Okay? And the manual therapy that has evidence is thrust manipulation or very specific mobilization. What we know also from evidence that no one can prove that you can individually mobilize a technique. It's impossible. It doesn't happen. There's lots of literature proving that. So, I understand that sometimes we have to use electrotherapy and acupuncture and soft tissue mobilization to keep the patient happy. Okay? But in the long run, it's informative for us to know why we're doing this. As long as we don't rely on the therapy.
From my side, basically, if you say that we should use the different approaches together, okay, we should use different manual therapy. But if you are doing this and I'm also doing this, if you want to do a research over a specific technique, then how will you strongly evidence your research? Because we are using a combination of techniques. Then how we can say that
what we do, I can answer that because I've done that before. So you take existing best practice, okay, which we know what that is. Okay, that's your control group. Because you can't have a control group where there's no treatment. That's not ethical, right? You're not going to get approval. So you take existing best practice, which is patient for chronic. Let's say chronic low back pain. What's existing best practice for chronic low back pain? Patient education, cognitive behavioral therapy, manual therapy with exercise, and exercise. That's your best practice for now. Okay? That's your control group. In your experimental group, you do the same thing, but then you add the one technique that you want to test. It could be a Mulligan mobilization. It could be acupuncture. It could be shockwave, whatever. Trigger point release, whatever. But that's how you, and then at the end of your research, if the group that receives the extra does better, significantly better, then you've shown with reasonable probability that you added technique could be the benefit. So that's how you could design a study to look at a new technique without compromising your study design by combining treatments.
Okay.
Makes sense?
Yes, ma'am. I just would support this point just because when I was doing my post-graduation research, so one of the post-graduation research is on the basis of Mulligan versus another manual therapy approach. So just I was, and on the basis of acute non-specific lower back pain. So I just would say that this is a strong point that we can say. Now, ma'am, I don't think so. There are some question because the concept and the way of deliverance was so outstanding that I only can strongly agree that the participants they understood all the basically what we wanted to provide. So, ma'am, thank you so much. Now we are just waiting for your words regarding for joining us and for your webinar. While the feedback I will provide you by tomorrow.
Okay. So I'm really happy that we got to work together, Dileep. It's a wonderful opportunity. Whenever I can talk to therapists from all over Pakistan, it makes me very happy. And I'm very active on social media, so please, if you have questions, if you want to collaborate, just contact me on social media. You've got my email as well, so feel free to contact me. And I hope that, inshallah, our profession continues to grow. The one wish I have for our profession in Pakistan is for you to get a council. When you get a council, you will have credibility and you will have autonomy. Okay? Only the young people in Pakistan can work together to give you a council. This should be a priority for you. It will give you credibility with the medical profession as well. And once you have credibility, your salary will go up as well, inshallah. So my one piece of advice would be try to get a council. I know it's hard. I know it takes time, but never give up. Try to get your own council. It's very, very important for the future of our profession in Pakistan.
No doubt. The council is very well, very mostly oftenly asked question by most of the students whenever they enroll. The fresh graduates they contact that, sir, we don't have a council, so should I join this field or not? But I would like to say that this is no doubt what we can say. The only possibility is to work as from a single page. If we are on a single page, if we work as a team, then we can achieve our targets. Ma'am, thank you so much for joining us, and the webinar was too much outstanding and no doubt very well informative. And all the data with your points suggesting, I will provide your presentation, no doubt, and I will provide these strong evidences that I was talking about. Thank you so much, ma'am, for joining us. Stay home. Allah Hafiz, ma'am. Goodbye. Thank you so much, all the participants. They are requested to put your feedback on YouTube in comment box and also CMT Facebook page. आप लोगों को अगर कोई भी question हो and अगर कोई भी question हो तो I am here to answer you. You can ask from my side. I am here for the few minutes to answer all your questions. If not, then put your like the video, put your feedback on our YouTube channel, put your feedback on our CMT FB page, and stay updated, stay connected with CMT for more upcoming webinars. And another thing I wanted to add that today is also another webinar from my side on a different YouTube channel, सोचना नहीं बोलना है. And my topic is cervical pain. I'm not only purely individually doing this. My another what we can say speaker is Dr. Shabana Naz. उनके साथ मेरा collectively cervical pain के ऊपर है, और वो उनका लिंक भी मैं आपको अपनी फेसबुक प्रोफाइल से जो है वो अटैच आप लोगों को मिल जाएगा. ठीक है, आज ही है 10:30 बजे 10 PM सर्वाइकल पेन. आपका कोई भी क्वेश्चन हो सर्वाइकल से रिलेटेड तो आप पूछ सकते हो वहां पे. और यहाँ पे अगर आपका इससे रिलेटेड वेबिनार से रिलेटेड लो बैक पेन से रिलेटेड है तो मैं यहाँ पे आपके लिए 5 मिनट हूँ. Thanks to Dr. Nimra and she is basically CMT Mirpurkhas ambassador, and the credit goes for the management. तो ये जो मैनेजमेंट है हमारा डिफरेंट वेबिनार हमारी डिफरेंट टीम्स चैप्टर्स को जाता है जिन्होंने ये सारा जो है वो ऑर्गेनाइज किया. तो क्रेडिट गोज टू डॉक्टर निमरा एंड हर टीम. बेसिकली उनकी पूरी टीम को ये क्रेडिट जाता है कि उन्होंने ये इसको अच्छे तरीके से ऑर्गेनाइज किया. आई वाज आउट ऑफ कराची बेसिकली, उसके बावजूद उन्होंने अच्छे से उसको मैनेज किया. थैंक्स टू हर एंड थैंक्स टू हर टीम बेसिकली. तो उसके अलावा अगर लो बैक पेन से रिलेटेड कोई क्वेश्चन है तो आप पूछ सकते हो. फर्दर मोर ये जितने भी जो पॉइंट्स थे एविडेंस के साथ ये मैं आप लोगों को प्रोवाइड कर दूंगा. कुछ पॉइंट्स पे मैंने मैम के एग्री किया था, कुछ पे मैंने डिसएग्री किया, तो वो भी मैंने आपके सामने ही उनके साथ मैंने डिस्कस कर लिया. तो यही चीज है, अगर आपको कोई भी पॉइंट जो है वो दिक्कत दे रही हो, कोई भी आपको डिफिकल्टी हो, यू कैन आस्क. यू आर नॉट ऑलवेज what we can say inclined to believe those points that we say to you guys. You are just doing you are just listening. If you have any sort of the query, if you are not agreeing with my point, you can put your remarks. You can ask me that, sir, what is the strong point or what is the evidence that you are talking about. Then we can say that I will provide you the evidence and all. So अगर आपको कोई भी क्वेश्चन हो इस तरह करके तो आप पूछ सकते हो हमसे कि, और हम आपको उनका एविडेंस प्रोवाइड कर देंगे. मैं अपने हर वेबिनार में 2-3 पॉइंट्स हमेशा ये कहता हूं कि आप लोग हमेशा एविडेंस बेस्ड बात करो. लाइक अगर आप कोई भी चीज यहाँ से उठा के वहां भी रखते हो तो आपके पीछे उसके पीछे लॉजिक होना चाहिए, उसके पीछे रीजनिंग होना चाहिए. ऑलवेज डू ऑन द बेसिस ऑफ एविडेंस, always talk on the basis of strong references, and always deliver with your clinical application and with your clinical experience, what we can say. बुक्स सारी सही, मैं नहीं कहता बुक्स गलत होती हैं, बुक्स ठीक होती हैं, लेकिन ये भी देखें कि उस बुक्स को सपोर्ट करने वाले कितने हैं. लाइक एक बुक है, कोई भी लिख ले मिसाल के तौर पे, अगर वो लिख के उसमें वो ऐसी पॉइंट्स ऐड करे जिसमें बाकी उससे मुत्तफिक नहीं है, उससे एग्री नहीं करते, तो डजंट मीन कि वो एक स्ट्रॉन्ग एविडेंस है आपके ऊपर, आप उसके ऊपर बहस कर सकते हो. सेकेंडली, थैंक यू सो मच गाइज फॉर वॉचिंग अस लाइव and put your remarks on CMT FB page. अब मुझे इजाजत दीजिएगा. I hope कि there is no such question on low back pain, and we'll see you on 10 PM from सोचना नहीं बोलना YouTube channel. Link will be provided from my Facebook profile. From my timeline will be provided to you, and put your remarks regarding, especially regarding our worthy speaker Dr. Habiba Thawer. She has cleared all the concept, and the way she delivered with her strong evidence, I would much appreciate, and definitely I will invite her again for another session, for another references, for another strong evidence. So please put your remarks and feedback regarding the webinar on our FB page. If there is no question, then I would like to end up this webinar. Thank you so much for joining us. Like the video and put your remarks. Stay home, stay safe, and Allah Hafiz. Take care.